It's live, sir. You can start now.
Yeah, Mithilesh, you can start.
Good morning, all. I'm Dr. Mithilesh. I'm a consultant intensivist in Medicover Hospital, Hyderabad. And in the case series of ECMO, where I'm going to talk about the preparation for ECMO, the last class which was covered on physiology of ECMO. After that, we are going to discuss about the preparation of ECMO. So, extracorporeal membrane oxygen, it is an advanced life support which was developed to treat the severe cardiac and pulmonary failure in critically ill patient, and it has been used to treat the patients with ARDS, cardiogenic shock, and some heart failure or lung issues after the transplant. It is also used for high-risk procedures such as tracheal dissections, ventricular tachycardia ablations, and complicated percutaneous coronary interventions. The use demonstrates the ECMO's ability to oxygenate and stabilize the hemodynamics in challenging clinical circumstances. So the clinical studies, they have reported survival rates exceeding 60% in ECMO assisted thoracic surgeries, underscoring its efficacy in this setting. So ECMO has been widely used in multiple critical patients where the conventional hemodynamic and respiratory supports are not enough for the patient. So in that scenario, when the patient with maximum ventilatory support or maximum hemodynamic support is not able to maintain his physiological status, then we need to start on ECMO support. The recent advances such as the portable ECMO system and artificial intelligence driven measurement tools have also increased the effectiveness of the ECMO. So there are two types of ECMO. One is VV ECMO and one is the VA ECMO. So this diagram depicts the veno-venous extracorporeal membrane where the two cannulas are there. One is the draining cannula which will drain the blood from the femoral vein, and then it goes into the pump, and from pump it goes into the oxygenator, and oxygenator it gets oxygenated and it goes back to the right side again, right circulation through the another venous cannula. So this is a veno-venous extracorporeal membrane oxygenation where function of the hemodynamics are taken care of by the heart itself, while the respiratory support, so it is a full kind of respiratory support, does not have any major cardiac support. So the blood flows back to the right circulation and again goes into the pulmonary circulation. This is used mainly in the patients with ARDS and any lung related support. This is the second type of ECMO, where you have veno arterial ECMO, where you have two different systems. Where in one system there is drainage of the venous from the venous cannula. It goes into the pump. It goes into the oxygenator, where the oxygenator functions as a lung, where it gets the gas exchange, where the CO2 is eliminated, oxygenation of the blood is done, and the blood comes back into the arterial circulation. The more important thing to understand here is the return cannula comes into the arterial circulation so that it can support the cardiac output. The organ perfusion and all is helped. So this is used mainly in the cardiac support, where the patient is having some kind of shock-like situation, where the patient is having cardiogenic shock, or the patient is having requires both cardiorespiratory support. The veno-venous ECMO, the draining cannula is just at the junction of the IVC and the RA, and it drains back mainly into the femoral artery. So here the few things. The most important thing is that when the blood is drained into the femoral artery, it increases the afterload for the heart. So the physiology has been discussed in detail, so I won't go in much of detail for that. And these are the basic forms of ECMO which we use in our patients. So today's lecture we come to the preparation for ECMO. So preparation for ECMO is can be challenging as the patient are critical. They are on multiple life support. They may be requiring high ventilator support. They might be on high vasopressor support. They might be having multiple other comorbids which makes them critical, and support of ECMO becomes initiation becomes more challenging. The more important thing in these patients are first is family. They need to understand what is the ECMO, that it is just a life support. It is not a kind of therapy. It can buy us some time so that the treatment can continue and the patient can show some recovery. Then second important part of preparation is medical team, manpower, and third is logistics. So it requires a lot of logistic support and a lot of trained medical personnel. So initiation of ECMO can be challenging. So the most important thing is family counseling. Already the patient might be sick. Patient might be in the ICU for a few days. He's already having multiple conditions where he's not recovering. So in that scenario, if there is worsening of respiratory function, worsening of the cardiac function, in that scenario, the family has to be explained that the treatment strategy. What are we giving? For example, a patient has come to us with ARDS. He's on maximum ventilator support. We have tried prone ventilation. He has not improved out of that. And why it is not working, we need to explain them in a simple word and then tell them that why it is not working and give them the option of VV ECMO in this scenario, right? The estimated duration of the treatment, we have to tell them what to expect out of the ECMO, that it is just a life support and it will buy us some time. How much time it may require, that may be not very clear, but we need to tell them. And we need to tell them about the exit strategy. So I'll come to the exit strategy in next slide. And financial implication. ECMO has been supposed to be a very costly affair previously, but it doesn't have to be that. More and more centers are doing. So they need to be explained about the financial implications. Some of the hospitals, they're giving some fixed packages for ECMO for some 4 days, 5 days, in which we can understand whether the patient is showing some improvement or not. So those things can be explained to the family. Some of the insurances are also being covering the ECMO. So all these things makes the ECMO a little more viable option at this point of time as far as finances are concerned. And the family needs to be explained those things, and informed consent has to be taken. They have to be explained that the risk, like there can be a bleeding tendencies, there can be another hemorrhages, there can be coagulation related problems. So all those things have to be explained to the family before commencing the ECMO, and informed consent needs to be taken. So this one simple thing, like if the patient comes to us, with the cardiogenic shock, maybe it is related to acute myocardial infarction, myocarditis, chronic pulmonary this pulmonary embolism with right heart failure. So if the patient is having cardiac arrest and the patient has been started on VA ECMO, so in this scenario, we can tell the family that it is either a bridge. So it can be a bridge to either recovery of the patient, where the patient completely recovers. For example, a patient comes with viral myocarditis where he has got a unstable hemodynamic support, unstable hemodynamics. In that scenario, if once you give the ECMO support over a period of time, the myocarditis improves and the patient can improve. A patient who has come with acute myocardial infarction, his coronaries are reperfusion has been done, revascularization has been done, and that patient can recover. So it can act as a bridge to recovery. Sometimes the patient may not recover, the LV function may not recover. In that scenario, we might have to, it acts as a bridge to the mechanical circulatory support. For example, few of the patients, they might require left ventricular assist device, and some of the patients, they might go for heart and lung transplantation. So when you start any kind of extracorporeal support to this patient, the family has to be explained in the clear scenario that these are the things. Or sometimes you have to take a decision where all these things are not possible. If the patient is having significant any post cardiac arrest, is a hypoxic injury and all, then we have to stop at some point of time. So the initiation or the preparation of the ECMO requires a teamwork, and the teamwork, generally it's divided into teams. One person will be leading the team; he will be taking the decision, and he will be coordinating with the other members of his team. So one of the important aspect is counseling team. As I told you previously, the counseling team will discuss with the family, will explain, try to sort out all the doubts, and what exactly the plan of ECMO is there, how it is going to, what is the exit strategy and all has to be explained to the family by the counseling team. Then you come to the procedure team. Procedure team will actually be participating in the procedure, where we will be cannulating the patient with ECMO cannulas, where we will be monitoring, where we will continue the perfusion. And also this is the procedure team, and one is a helping team, non-procedural team, where we have our bedside nursing staff, which will help us in doing the giving medications, monitoring the pressures, monitoring the hemodynamics, monitoring all the vitals and ventilator management in these patients. So the non-procedural team, it consists of a bedside nurse for handling drugs, infusion pumps, because the patient is already not yet on ECMO. He may be requiring high vasopressor support. There might be multiple medications, multiple infusions which are going for these patients. The patient positioning, preparation for the ECMO, all these things are being taken care of the non-procedural team. Checklist needs to be seen by those people to be supervised. I'll come to this checklist in detail, because the preparation of the ECMO, we need to have some good checklist which will decrease the risk of any of the mishaps during the procedure. Quality control and vascular surgeon or the cardiac surgeon backup. So in scenario, sometimes if the patient is having some complication, for example, patient having small vessels, if there is a trauma or there is a rupture of the artery, there can be a significant hemodynamic instability because of the blood loss. In that scenario, we need to have a vascular surgeon or a cardiac surgeon backup. We had one patient who had got very small femoral artery. While cannulating, there was a injury to the femoral artery, and then we had to convert the percutaneous cannulation procedure to a surgical cannulation, open cannulation. So the other important thing, we come to the logistics now. Once we have gone with the counseling team, procedural team, and support team, here we can see a ECPR team, ECPR trolley. Here, all the, if you see it in properly, there are multiple compartments where it is already one thing which is already prepared for ECPR. So here in the side where we have multiple cannulas, the multiple size cannulas are there which are available, and here, if you see, there are the numbers of the cannulator, first cannulator, second cannulator. These might be the duty mobiles also. So in any kind of ECMO initiation or preparation for ECMO, the most important thing is manpower. Somebody who can cannulate the patient during an emergency, for example, ECPR, or a patient who has got severe cardiogenic shock. These patients may not give you too much of time. If at all you are starting ECMO for a patient who is having ARDS requiring VV ECMO, in that scenario, you may have some time where you can actually plan and do it. But a patient who is having the cardiac arrest. For example, a patient who comes to you with acute myocardial infarction, has a cardiac arrest in the ER, eCPR can be initiated at the time where you start with the CPR, which can be machine CPR also, and at the same time you start cannulating the patient. So this thing has to be ready so that it saves time. So this part, it contains the multiple cannulas which can be used according to the patient. For then first stop is PP. Initially, you can have some gowns, surgical gowns, and ECMO insertion packs. So here in second thing, you have ECMO insertion packs, which will have your guide wires, which will have the cannulas, which will have the dilators, and the bags, perfusion cannula. Those things will be there. Wires and dilators are kept here, and sutures and dressings are kept here, and ECMO extras. If at all you need extra needles, extra dilators, cannulas, and all those things will be here. Surgical cut down, if at all it is required, it is here. So once you open it, the same this trolley, the top of the trolley can be used for this thing. You can keep a sterile bed sheet on that, and you can keep the multiple things. You can keep the puncture needles, you can keep the dilators, and it can be used. So opening instructions are given. Then you have the numbering matches with this thing. In some of the ECMO trolleys, they have already given that the cannulator 1, cannulator 2. So for everybody has to open that one particular compartment, take those things, and the time and confusion is saved at that point of time. It is color coded. It can be easily identified, and you can use the things properly. So the things which are used for the ECMO, important in ECMO preparation, is to have a proper circuit, oxygenator, where we have the oxygen connections. This is for the ECMO machine. This is the flow meters. This is the flow meter for the oxygen delivery, and this for the sweep gas, and ECMO pump device. So these are the things which will be there in the ECMO complete assembly. So cannulation team. So the cannulation team, the team lead, he will coordinate with all the people, identifying the major issues and try to correct them. Patients' vitals need to be monitored very closely. One team of the doctors or the support team will look for the infusion, taking care of drugs, if at all, giving some volume, vasopressors, and taking care of vitals. And one team is required for cannulation. Ideally, 2 to 4 people are required for the cannulation. Where in the case of arterial cannulation, one person will cannulate the femoral artery, and one person will cannulate the femoral vein. The circuit priming will be done when you start cleaning and draping for the patient. The circuit priming will be started. So by the time your whole assembly is ready, by the time the circuit priming will also be ready, and you can use it while you connect the cannulas to the circuit. So logistically also, it is very important because here, if you see, the patient is having multiple supportive things. Here ventilator is there, infusion pumps, monitors, ECMO machines. So it takes a lot of space. So approximately almost 1.5 to 2 bed space is required. So whenever you are starting ECMO, always make sure that you are having enough space to start this thing. You may require a echocardiography machine where you check for the position of the cannulas. You may require the ultrasound machine because all all the punctures in ECMO guided ECMO, especially in your arterial ECMO, you'll need ultrasound guided punctures so that you can do the punctures correctly. And in that scenario also, because if the hemodynamics are not good, the arterial gush may not be that good, and you may be confused. So in that all the scenario, whenever you are doing punctures, it is always better to do it ultrasound guided. So you need an ultrasound machine, you will need an echo machine to confirm the position of the venous cannula or the drainage cannula. So all these things are very, very important. So all of them, they take enough space, so the space should be there. So now you come for the special situations. Special situations such as outreach situation, where you want to initiate ECMO in a remote hospital, and you manage there with the support of the local doctor team, that hospital team, or sometimes you initiate the ECMO in a remote location and transfer it to your center. So what are the important points where you start initiation in management? You need to understand the hospital where you are going, whether it is a this tertiary hospital, or what kind of facilities they are having. Do they have all the kind of monitoring facilities? Do they have ultrasound machine, echo, X-ray, ABG, ACT? All those facilities are there or not? ECMO equipment such as echo machine, do they have their own echo machine and circuit, or do you have to take your echo machine and circuit over there? Ultrasound for the punctures, the chest X-ray to confirm the position of the cannula, ABG machine to do the repeat ABGs, ACT machine to maintain the anticoagulation, multi-para monitor. Blood bank and blood products are also important part of the preparation for ECMO, because if at all there is some bleed and all, the patient may require blood products in that scenario. So the blood bank where the cross-matched blood products are already ready is always required. And distance and the way of approach. So how far that hospital is, how are you going to go there? Are you going to go there, and how are you going to come back from there? So is it a road transport, or is it a air transport, which you are planning, that we need to plan? So whenever you are going to a remote initiation, we have a good checklist for this. And the last, we'll discuss about the checklist where we go systematically through these things. But these are the basic things which we need to understand. Understand the hospital where you are going, what facilities they are having, all the equipments they are having, or do you need to take some equipment? If at all, you can send them some checklists and make them to arrange few of the things for you. A good blood bank and blood products. And here also one important thing is that some surgical backup is always required, because in case any complication, anything happens, that will be a new place for you. So any surgical backup is always advised. So if at all you're going by the flight transport, you need to understand that whether you need to have adequate oxygen. You need to have 2 oxygen cylinder, one for your ventilator, one for your ECMO. So how much time that air travel is going to take, how much oxygen it is going to require, that you have to calculate. The oxygen cylinder should be full, and depending upon the time of journey, whether that oxygen is going to be adequate and all has to be initially only calculated. The power and the battery, whether whether the aircraft has got a power or to support your ECMO and ventilator, or whether your ECMO batteries will have to be used in that scenario. How much is the duration? Whether your batteries will be sufficient for that much of time. Also, we need to understand logistics while transporting the patient, the ambulance, taking the patient from tarmac to again your aircraft, again getting him down. So all those things are very important. Mainly from your ICU, where you cannulate the patient in outreach ECMO, you take the patient to ambulance. From ambulance, the patient is again shifted to air ambulance. From air ambulance, again it comes to the ground ambulance, and again comes back to the receiving hospital. So this whole chain of event is there, which has to be meticulously planned. So preparation has to be done properly, where we have communication with the patient, with the doctors of the treating team over there, to find out really the patient requires any ECMO, whether the family is willing for ECMO or not, whether the consents have been taken, whether the patient has been clearance for the air ambulance has been taken. So all those things are logistic things, those things need to be taken. And most important is hand crank. So the patient should have the ECMO circuit should also be having hand crank, where in case of power failure, you can support the patient during an emergency. So here the very small thing I wanted to make a point that the air ambulance may not be big aircrafts. They are all very small aircrafts. From inside there will be a very small space where we can keep the patient, and there will be very little space for the treating team to be there. So it becomes very challenging to manage ECMO. As you have seen, there are all multiple tubings and multiple tubings for ECMO machine, and your ventilator tubings, all these things. To manage all these things here, it becomes challenge one. Taking the patient from the tarmac to air ambulance itself can be challenging. So that is also to be planned properly. The long tubings have to be kept so that the oxygen cylinders and all, even if they are down, we can shift the patient inside. So long oxygen tubings are required. Then this height may be somewhere around 4 feet somewhere, so you have to lift the patient. So you'll need multiple support staff will be able to transport the patient right from the tarmac to the air ambulance, and vice versa. So all these things become very challenging when you're shifting the patient through ECMO. So important thing when you are saying about preparedness. So being prepared means we need to see all the things. Standard checklist, transport checklist is whether the ECMO equipment, ECMO oxygen cylinder, whether it is full or not, ECMO oxygen cylinder, whether it is connected to oxygenator via green tubing, ECMO battery should be charged. So all these things, ECMO equipment should be working well, and cylinder should be full, and the battery should be completely charged. There have to be role assigned to everybody. One person will be taking care of the airway, high flow cannula airway. One person will be taking care of ventilator. So sometimes the patient may not be intubated. Like sometimes the patient is having a ventricular septal defect post acute myocardial infarction. In that scenario, he needs what he needs is only a cardiac support. So in that scenario, the patient may or may not have a airway support. He may not be intubated. But if the patient is intubated, somebody has to take care of the airway. It may be ventilated. It may be high flow cannula. Then the patient, somebody has to take care of the ECMO lines, ECMO console, and if any extra assistant is required for the infusion pumps and all, those needs to be done. So proper distribution of the roles has to be done, and a departure plan has to be done. So the departure, for example, if at all it is in hospital plan, where are you, if it is a in hospital plan, where are you shifting for a CT scan or something like that, or if you're shifting out, what is the best time if you're shifting him out, if the ECMO circuit fails, what will you do, what is the plan A, plan B. So all those things need to be done. When you come back to destination, again the standard checklist has to be done, like roles have to be assigned, the ECMO equipment have to be checked again, and the oxygenator, and we have to connect the ECMO oxygenator to via the green tubing. On arrival to IV ICU, again we connect the standard monitors, and again check for the ECMO flows and connect the oxygen cylinder and all. If at all it is required, or we can go for the regular hospital oxygen supply. So this is a basic checklist for where you checklist for the transport, where you check for the ECMO equipment, role assigned to different people, plan for clear cut departure, arrival, and while you come to the ICU. So mobile ECMO checklist. This is a checklist for the remote ECMO initiation. So as I told you, there has to be clear-cut communication. So type of ECMO referral, whether it's a ECMO referral for VV ECMO, whether it is a referral for VA ECMO, what decision you have taken, what ECMO are going to put, what is the mode of transportation, are you going to get the patient back either by road or by air ambulance, that has to be decided. So these three things have to be decided. So the team leader has to be decided, who are going to be the part of team members, those things have to be decided, and emergency medical services, ambulance services to be informed. So we have to inform, if at all you are coming by the air ambulance, you have to inform both the hospitals that this patient is getting transferred, so that the this air landing service permissions and all needs to be taken. Emergency, if at all emergency, if any kind of outside cannulation, anything happens, then what is the plan that will to be arranged? Bed arrangements have to be done. Necessary permissions from the this aviation authority, clearance and all needs to be taken. In case outstation, out of country, then visa and all needs to be done. So this first part comes as communication, whether the patient needs ECMO, what kind of ECMO he needs, what are the team members we are going to go, what are the instructions we need to give them, all these things, and all the kind of permissions needs to be taken. So communication forms very important part of the ECMO preparation. Second thing is referring facility. When we speak to the other hospital, tell them that the right radial artery preferred, because if at all it will be able to give us better information about the oxygenation, and sometimes harlequin. So that is one thing. If the patient has a central line, it's always good. They have to avoid groin if at all it is possible, because you might use the femoral vessels for access for the venous and arterial cannulation, the ECMO, and any sedation, paralysis which is available at the bedside, blood which has to be cross match, FFPs which has to be cross match, and the platelets need to become. So all these things they have to arrange. So central line, arterial line, sedative, paralytic, blood and blood products, operating room or the your cath lab where the procedure can be done, imaging like chest X-ray. These all we have discussed previously, but this is a standard checklist. If you say that this has been there, then the success and the safety of the ECMO initiation or ECMO preparation becomes good. And when you are transporting, whether the trolley cart is there, console, power cord, bridge, all those things we need to see. And always it is important to understand that always better to have a spare oxygenator circuit. If at all your patient is having pulmonary thromboembolism and all, in that case there might be sudden flooding of your circuit and your oxygenator with the clots. In that scenario you may not be able to run the ECMO efficiently. So in that scenario you may need another oxygenator, you may need another circuit also. So all these things, having extra cannulas, extra oxygenator circuits, and your connectors. Sometimes if at all the patient has a cardiac arrest, in that scenario you may require a Y connector and one more cannula where you can do a arterial cannulation and you can convert the VV ECMO to VVA ECMO. So all these things we need to keep in mind. All the things needs to be planned meticulously. Then only we'll be able to do a successful ECMO. So one more special situation is out of hospital cardiac arrest. Out of hospital cardiac arrest, if the patient is having, so the basically out of hospital cardiac arrest, you can do ECPR, ECMO CPR. The principles of ECMO CPR is the conventional CPR we need to start, and we need to do a good quality conventional ECMO CPR. At the same time, when the people are shifting the patient, they identify the patient is an ECMO candidate. If the patient is having VF cardiac arrest or VTVF cardiac arrest, the chance of the patient survival are better. If the patient is having asystole, the patient is having asystole for more time, the duration of CPR for more than 30 minutes or 60 minutes, scenario, the patient may not be an ideal candidate for ECMO CPR. So this patient can be shifted to ECMO, closest ECMO initiation hospital. At the same time, the code ECMO is initiated in the hospital. All the people who are part of the code ECMO, they get activated. They will either the two process will be there. They go to the site and do ECMO, which is done in few of the European countries, or they can transfer the patient to the closest ECMO initiation hospital depending upon the decision which is made. And in the emergency, the cannulation has been done. The perfusion team does the priming of the circuit. The cannulation team does the cannulation, and the CPR is continued according to the conventional thing. And the ECMO CPR can be done. So ECMO CPR, they have shown that the outcomes may be little better in few of the studies, but not become a standard of care till now. So this one interesting article I want to share this. This was published in Elsevier in European Resuscitation Council. Here they had the pre-assembled ECMO, and which enhanced the efficiency of the ECMO initiation or preparation for ECMO and reducing stress in the refractory cardiac arrest care. So here the perfusionist has already kept the circuit primed. So this is a primed circuit which is kept at all points, at all times, which is available in the hospital. So in case any kind of emergency comes, like a patient who comes with the cardiac arrest because of some reason, for example, a patient who is awaiting a for example, a patient who is awaiting heart transplant, he does suddenly has a cardiac arrest, he can be initiated on ECMO. A young patient comes with a acute severe myocardial infarction, cardiogenic arrest can get immediate can be put on ECMO immediately if the priming circuit is ready. So what they found out, that three or four things they tried to see. They try to maintain a sterility of 21 days period and expedite ECMO initiation in ECPR patients, alleviate the psychological burden. So what they found is that they did multiple cultures. Every 7 days they sent the culture from this primed ECMO circuit, and they found that all out of 120 this thing cultures, none of them was positive. So they concluded that the ECMO circuit can be maintained without any kind of infection. That is one thing. Second, the time to ECMO initiation is significantly reduced. For example, it has decreased to 13 minutes as compared to 31 minutes in the other things. So that is one thing. The time of initiation of ECMO has improved. This can give the support in a better way. and it has considerably decreased the psychological stress on the treating team. So three important take points from here is that ECMO circuit can be primed and kept. So if you're doing ECMO once in 21 days also, in that say scenario also, you can use you can keep one circuit primed and you can use it. So this is one thing which seems little interesting. And as far as another last slide, I will go for pre-initiation checklist, where you do a timeout and briefing, circuit, cannula, everything is confirmed. Integrity, sterility, and expiration is verified. Your flow meters, gas lines, circuit connections are secure. There should be a circuit, and circuit should be air and leak free. Hand crank should be available. So all these things, they should be there. So the most important thing which when you prepare for an ECMO is one. So the few things which we need to understand when you prepare for ECMO, the most important thing is the preparation should have a proper counseling team, a proper procedure team, and third is your support staff. And with a lot of ECMO training these days, if you have a proper ECMO training, the amount of stress and procedural complications will come down over a period of time. That is very important. There are simulators which we can use, or there can be a practical hand-on things which will help you to prepare for these kind of emergency situations on mannequins. That can be done. You can always have some kind of support from the surgeons in case any kind of bleed and all is there, and percutaneous procedures can be converted into open procedures. And any kind of bleeding and all, we need to have some good support from the blood bank and blood products like PRBCs, FFPs, and platelets, which can be transfused in these teams. So these are all things which becomes very, very important in starting in preparing yourself or your team for ECMO. So that is the crux of the whole topic. Thank you. The most important thing, one more I wanted to tell is that the more you prepare during the peace, the less you bleed in war, is what is the old saying. So more you prepare or more you push yourself during the training period, the less are the chances of having any complications, bleeding or anything during your preparation and implementation of initiation of ECMO. Thank you.
Kancham?
Yeah, yeah.
Kancham?
Yes, you must. Thank you, Mitlesh. See, I mean, ECMO is something which many centers are doing, and I'm sure Srinivas would also kind of reiterate what I am saying. When we started our journey in the initial stages, getting an ECMO initiated would take a long time. There used to be many challenges. But as you keep doing ECMO, right, from a point where for us it would have taken a few hours to initiate ECMO, now we have come to a point where we can initiate ECMO within a few minutes. So I think it's just keep doing it. So what is going to make you ECMO ready with as little complications as possible? Because the more you do, the more you train, the roles. One thing we all need to understand and agree is that there are multiple players and multiple teams which are involved when you're initiating and managing an ECMO. So the more you do, it becomes very clear to each member of the team as to what his role would be, so that when the actual initiation comes, there is no confusion and things move on smoothly. So it's always better, even if you don't have many cases running on, once in a while the team should come together and review your preparedness. And those are a couple of things which I thought we should always be investing in if you are running an ECMO program.
Thank you, Kancham. Thank you, Mitlesh, for highlighting the role of preparedness in ECMO.
Thank you, sir.
We meet again next week with another topic related to ECMO.
Thank you, sir.
Subscribe to our YouTube channel.